This is SG2 Perspectives, a conversation with SG2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
I would say a great first starting point is look at the patients that you treat. Many health systems have something like a community needs assessment. Look at your inpatient discharges. Do you see one specific disease a lot more than others? Some systems may have a lot of pulmonary conditions. Maybe they have a really high prevalence of disease for chronic obstructive pulmonary disease. Maybe they're in a rural community with high smoking rates. That might be a great place to start.
Hello and welcome to SG2 Perspectives. I'm your host, Tori Richie. Today, I am joined by two of our experts, Jen Goff and Emily Fitt, as we explore all things epidemiology based on the latest highlights from the Impact of Change forecast. Great to have you both on the podcast today. I selected you two specifically because medicine is Emily's domain and behavioral health lives with Jen. There are a lot of epidemiological drivers for these unique clinical subsets. I wanted to dive deeper into some of the headwinds that organizations are facing as they think about managing these unique patient populations. I want to play you back a quick clip from our overall IOC podcast from a few weeks back.
One of the impact factors that can feel academic, but is also super interesting and the place a lot of us spend time and energy is epidemiology. Which trends, patterns that we were paying attention to were big enough and clear enough that they made it into the forecast?
Chronic disease is always a big one. That's an area where we just continue to see increased incidence and prevalence within the population. We as communities are not healthier now than we were 10 years ago. And short of something substantial changing, we're not there yet. We know it's going to take a lot of time to transform the epidemiological realities of our society, and we expect to see continued growth in that area. Emily, Jen, that'll be the quote that we ground ourselves in. Emily, I think about chronic disease and some of the growth in terms of increasing prevalence that we've seen there is certainly something that you keep your eye on. What is the latest on that front? What are some of the key trends that health systems should look out for?
When I think about epidemiology changes, I think about a couple of things that are driving that. Number one, the incidence and prevalence of overall disease. We can look at historically where has disease been increasing, has disease been declining. We have some great examples of diseases that have been declining, like tuberculosis or hepatitis. We have negative epidemiology impact factors for those diseases. But on the flip side, medicine is comprised of chronic care, chronic disease. A great example of this is end-stage renal disease, because we see year over year that incidence is flat. We're not necessarily gaining a swath of new end-stage renal disease patients. But what we are seeing is prevalence continues to rise, which means people are living longer with end-stage renal disease. Therefore, epidemiology is growing. We're getting more and more people every year, but we also have to treat patients that have this disease. That's a more end-stage tertiary disease, but we are also seeing this for some of our lower acuity conditions like type 2 diabetes, hypertension, hyperlipidemia. We're starting to see chronic disease is rising for a number of different factors that we can chat about later. We're seeing incidence is really continuing to grow, but people live longer with these diseases.
I love that. And I think about then the parallel circumstances that are playing out in behavioral health. Jen, could you describe some of the reasons why we continue to see behavioral health demand grow?
If we take a step back, just to give perspective on behavioral health growth. So in our forecast, overall behavioral health is projected to grow 6% on inpatient and 24% on outpatient. That is huge growth. Most of that is epidemiology. When it comes to epidemiology and for behavioral health, it's around what is happening in the society, what is going on now that could be impacting people's stress, their anxiety, making them very anxious. And how will that continue? Great examples on the behavioral health front is that the last few years, even starting pre-COVID and then even into COVID and now, is there are a lot of stressors happening around us in the US, even globally, and we have access to everything on demand. And in this year, particularly, there has been a media overload, particularly around the uncertainties with our economy. I'll just use this as the stressor and anxiety that people are feeling is we've gone through the last year on inflation. Media has continuously expressed it, right? You can go on social media and see about the economy. The stock exchange is up and down. People are afraid. Am I going to lose my job? Or am I going to be able to pay my bills? We know housing and food is going up. So people are stressed. You continue to see it social media. That's the other big thing. There's been a lot of research of the utilization of social media and how that impacts and can create more stress for individuals. There's a lot of gun violence that we continue to hear. This year, people are probably afraid to even fly. Media has really emphasized flying. When it comes to behavioral health, we have to think about what's happening in our society. How is technology changing people's behaviors? And what we're seeing is more people are anxious, they're burnt out, they're depressed. Part of that too, we're seeing more substance use disorders. People sometimes turn to that. So that's just some examples of how epidemiology and it's growing the demand, because what is unique about behavioral health is in the past, people were afraid to talk about it and didn't recognize the impact stress and mental health distress has on your physical and your relationships, that now people are like, I am not okay and I want to talk about it. So that has been a win from COVID, that we're starting to see people talk about their mental health, which is driving up part of the demand. They're more aware, they're more recognizing it, particularly the younger population. There's still some stigma in the older population around talking about mental health, and there's still a lot more work we have to do there. But we continue to see this more, I'm aware, I'm okay talking about my mental health. Substance use, we still have a lot of work there. There's still people who are not talking about, or they feel like I have it under control. There's still some work there, but on the mental health side, we've made this comeback. I'm going to say the positive of social media. We've shed the light on mental health and making people feel good that others are talking about it, particularly celebrities. That's also contributing as well, which I call it the positive win that we continue to see on the behavioral health side.
What I think is so interesting about behavioral health is there's also a lot of investment in this area from the health system side. Could you speak a bit about how that is improving then treatment pathways and our ability to manage this influx of demand?
That's going to be another great win, is people are recognizing, and we continue to talk about the impact mental health, mental distress has on your physical health and other parts of it. And what we're seeing is because there's a shortage of providers when it comes to behavioral health, health systems realize there is this surge. I've heard comments from the behavioral health industry that we went from a COVID-19 pandemic to a behavioral health crisis. Health systems are recognized we're in a crisis, and these patients were showing up in the ED. And that's not a great place for someone that is already anxious or very depressed or suicidal. So what we're seeing is health systems investing across the care continuum. SSM, we did a podcast previously about them. They created a walk-in urgent care clinic that created a different access point. We're also seeing a lot of investment on the ambulatory side, earlier screening for people, particularly primary care is screening more and more. They're tracking people's depression and anxiety and screening them earlier and creating an earlier intervention. Employers is another great where we're seeing a lot of investment into an employer assistance programs, would typically offer mental health services as part of that, because they're realizing my employees are stressed. Everybody's stressed. We're hearing it in the media. And so the employers, they're recognizing it too and creating these access channels as well. So we have health systems as well as employers continuing to create these access points.
Emily, from your perspective, medicine for a long time has been severely underfunded. It hasn't been the revenue driver that some of the other service lines are for health systems. And as a result, then it doesn't get the love and attention that it frankly deserves. In a similar vein as to the increased access, the increased investment in expanding site of cares, or perhaps even piloting new programs, are you starting to see those activities take place at health systems to get this chronic disease epidemic under control?
We've seen it take flight in some disease states, and in others, we haven't seen it lift off the ground. A great example of this is type 2 diabetes. We see comprehensive diabetes programs done at so many systems, especially focusing on ancillary providers. So having somebody like a diabetes educator who can be a nurse, a registered dietitian, a behavioral health specialist, but it doesn't have to be a physician that's doing a lot of the boots on the ground work. We also see this with the implementation of community health workers for diabetes health programs, or even programs related to chronic disease, like somebody has hypertension and is overweight. We are seeing more of an investment in that. Part of that might have to do with the increasing awareness of the conversation surrounding obesity. GLP-1s, you could have a positive or a negative overall reaction to them. One thing that they've done that's positive is they've opened up the conversation of obesity, and they've opened it up to obesity is not something that's rooted in morality or rooted in stigma. It is a disease, and we should treat diseases with medicine. So we've started to see health systems invest in that just because patients are wanting it. Consumers are wanting that. And we're seeing more disruptors enter this space because health systems aren't meeting that need. We still have a lot of work to be done in the chronic care space in medicine, but there are a few bright spots.
Where would you encourage health systems to focus? Where should they begin to get control on the situation and ensure that consumers are surrounded with those services that they need?
A great first starting point is look at the patients that you treat. Many health systems have something like a community needs assessment. Look at your inpatient discharges. Do you see one specific disease a lot more than others? Some systems may have a lot of pulmonary conditions. Maybe they have a high prevalence of disease for chronic obstructive pulmonary disease. Maybe they're in a rural community with high smoking rates. That might be a great place to start. So think about those high utilization, high inpatient discharges to get the greatest bang for your buck on that starting point.
Jen, from your perspective, even though we've seen investment in scaling behavioral health efforts, where are we still weak? Where do we still have gaps?
We have a lot of gaps still in rural areas. The larger health systems, where it's more populated, we've seen that more care continuum and that investment there. There is still a lot of work on the behavioral health side. There's still a lot of an unmet need. There needs to be awareness there. Another area is the serious mental illness population. This is more of a chronic that needs more care management and needs wraparound services related to them. They typically have higher utilization on both the physical and the mental side. But how do we create a system that works for someone with a more chronic mental illness like schizophrenia or bipolar disorder? I'm starting to see more investment there and starting to see new models appear in that space. We're creating access, but there's still fragmentation in behavioral health. Where people need to invest in is how do you navigate and get these patients to the right care service, the rare care site? Like, where do they go? Even though we're creating these great access points and we now have more access and people are receiving mental health treatment, is it the right treatment for them or not? So how do we create almost these navigation hubs to really redirect and kind of assess them quickly and decide what is their path? And when is their level increasing that they need a higher level of care earlier on, not waiting till they're in the emergency department and suicidal? That's where I see some gaps that still need to happen.
Both of the service lines that you two own are also very common comorbidities that patients that have other primary diagnoses are experiencing. Could you talk a bit about the importance of standing up those disease management programs to help prevent that heightened acuity if folks do require other medical or surgical services?
We see a lot of overlap in things with medicine. First, behavioral health. Absolutely. Seeing those conditions for patients with chronic disease also having something like anxiety or depression. On the substance use side, a few things that I'm really focused on for my hepatology service line is alcohol utilization, alcohol cessation programs. For my pulmonology service line, I'm really focused about smoking utilization and now vaping and marijuana utilization, smoking cessation programs. There's that overlap of, hey, we can treat you before you reach advanced liver disease or before you reach chronic obstructive pulmonary disease. And meanwhile, we still want you to get screened if you meet the criteria so we can continuously monitor you so you don't reach that point. Or if you do reach that point, we can intervene early. The other area I talk about a lot with our cardiovascular lead, Josh, are cardiometabolic clinics or cardiometabolic programs. So the intersection of metabolic disease like type 2 diabetes with cardiovascular conditions, think congestive heart failure. This accounts for a very large portion of the population that either have one, the other, both, and or. Thinking about you already have these patients in your community. You're already treating them, but the way that you're treating them is incredibly siloed. You have to go to your endocrinology appointment, then you have to go to your cardiology appointment, then you have to go to your dietitian appointment. It can become very overwhelming for the patient and or their caregivers. What if we created something like a one-stop shop for a patient with multiple chronic conditions, whether that be something like substance use or something like a cardiometabolic clinic? Thinking about where those natural ties and those natural crossovers occur can really help shape out the patient journey to not get to a point where they're needing inpatient care or they're going to the ED frequently.
Love that idea of centering it around the patient and the patient's needs. So behavioral health, we touch almost every single other service line. We've done a lot of data through using the Vizient clinical database. We know that just on inpatient discharges, it's like 57% of those have a behavioral health comorbidity. And we know that those that have a behavioral health comorbidity, they have a longer length of stay, they have higher readmits. It really impacts the physical outcomes. There's been so much research around this. We all know this. The behavioral health touches so many patients. And because of that information, patients know it now too. So that they're making more aware of the impacts their mental health has. We've been seeing integrating behavioral health automatically in the process and seeing primary care as well as specialty care screening for depression and anxiety. Substance use has a lot more work to do, screening for substance use disorder. But to be more preventative, a really cool model that I was reading about recently, it was a hospice palliative care organization. They've integrated behavioral health in, but they did it in a proactive approach for the patient that's in palliative or hospice, providing behavioral health services, which is common. They proactive that when that patient dies, they offer behavioral health grieving services to the family up to 13 months. So a full year of grieving to prepare them and help them understand the grief that they just had. They just had a family member pass away. Grief is a hard process, and they're proactively offering it automatically to these patients' families. That is a more proactive approach. Something like that where we know grief's hard and people are going to struggle, it's doing that proactively. I was like, that is a way to integrate behavioral health in a unique way compared to, we're doing a lot of screening. And if they screen positive, they bring behavioral health in there. But I was like, this is something that's going to be hard and we know people struggle. So let's just proactively offer it and do it.
That's amazing.
Yeah, it's a hospice palliative program in South Carolina. I was just reading it. I was like, this is a cool approach. We need to do more of that. We have to think about those diseases that are really difficult. I have a heart attack. That's a very difficult life, stressful situation. Do you just proactively just start treating them and counseling them right from the start about what they just experienced? We can do more and more of that. We're going to prevent that patient from experiencing stuff down the road.
Yeah. I mean, imagine heart attack, strokes, cancer, trauma occurrences, anything that could be a severe emotional trigger that obviously could then lead to anxiety, depression, what have you. That's amazing.
So any way we can lean that way too would be awesome. Centering around our patients and giving them more of that more consumer perspective. There's this proactive approach we can do automatically for certain diseases.
Anything to help take the burden off of the consumer. So often you hear, you need to be your own healthcare advocate. Well, it's incredibly difficult for people that don't work within the healthcare industry to know how to advocate for themselves. If we're able to then stand up those guardrails and have those support services available, why not take that more proactive approach? I mean, you can better communities by doing so.
A common misconception is that you have to have a physical space to house all of this care coordination for patient populations. Some of it may have to be done in person, but focusing on your virtual footprint and your remote patient monitoring footprint can go so far in a chronic disease population.
And that can help bridge the access gap that exists then for rural communities especially. I want to turn our focus a little bit to pharmaceutical innovation because both of your all service lines are definitely seeing the impact of continued pharmaceutical development in terms of treatment pathways and what have you. Could you talk a little bit about how new drugs or new indications for drugs are perhaps changing the type of demand that patients are experiencing? Emily, the first one that comes to mind, we can't go a podcast without talking about the GLPs.
We've done a podcast on GLP-1s. Go listen to that. It's really great. I speak with two of our pharmacy colleagues at Vizient. I'll put in a plug for GLP-1 again. GLP-1, super buzzy. We all talk about it. I want to look beyond the BMI. We should talk about obesity. We should talk about that this drug could do fantastic things to patients with obesity. But let's look at it from a chronic disease lens. We've seen indications for sleep apnea and heart disease in the past couple of years. We've seen fantastic studies surrounding metabolic liver disease and chronic kidney disease. We will see indications for those two conditions for either semaglutide or tirzepatide coming up within the next year. And then from there, who knows? I've seen studies of this pharmaceutical in cancer. I've seen it in dementia. I've seen it in inflammatory bowel disease. So right now, it's a testing phase for all disease. This could really open up a door for better chronic care. In initial data, we've started to see that patients on GLP-1 have fewer ED visits. They have fewer inpatient stays. And the results are pretty immediate when a patient starts taking that GLP-1, that they see this decrease in utilization. But the catch is that when the patient stops taking the GLP-1, their utilization goes back to normal. Their risk is back to normal for cardiovascular conditions or type 2 diabetes worsening, whatever it may be. It's not only getting folks on the GLP-1, it's keeping them on the GLP-1. And we should be focusing on our chronic disease population to begin to roll these medications out.
Jen, from your side of the house, when I think about pharmaceutical innovation over the last few years related to severe mental illness, substance abuse, and what have you, how are you seeing new therapeutics change the course of the behavioral health landscape?
I just want to add a little bit on to the GLP-1s because there is a connection on the behavioral health side. There has been a lot of studies on the GLP-1s and the reduction of alcohol use. There continues to be more of that. So it's something we are watching on the behavioral health side if that will help with our alcohol use disorder treatment there. The other thing I just want to mention, since this is an epi section here, is the one thing we've been watching and monitoring is this increased use of GLP-1s has created, especially with social media, again, is this emphasis on body image and losing weight. One of the care families underneath behavioral health is eating disorder. That is one area we are projecting that we will see an increased rise in eating disorders as there continues to be more emphasis about body imaging, particularly around losing weight. Some of this has been emphasized through all of the advertisements of GLP-1s and people showing, hey, I'm on GLP-1s, I'm losing weight, and creating this more. And there are people that's susceptible to that impacts them. So that is one area we are looking at. How does GLP-1s impact our eating disorder incident rates as well? So just want to make that one connection since we're on a
On the non-GLP-1 side, last year there were some new indications for some of our autoimmune and inflammatory medications, primarily for pulmonology diseases. We saw medications that are commonly treated for plaque psoriasis, rheumatoid arthritis, inflammatory bowel disease, get new indications for asthma and chronic obstructive pulmonary disease. That's really exciting because now we have an additional tool in our tool belt to treat these chronic patients. These are provider-administered injections. We're seeing some really great results so far, specifically in COPD clinical trials. They found that adverse events were reduced by 34%, and an adverse event was defined as an ED visit, an inpatient stay, or mortality. That's a pretty big reduction in utilization just by one additional medication being added onto the treatment pathway. What this means for health systems is you're going to need space to give these types of injections. A lot of health systems are focused on their infusion landscape and their footprint, but thinking about what are those different types of chairs that I need. A patient with chemotherapy is going to be a different patient than a patient receiving a biologic, than a patient coming in for an injectable where we watch them, make sure you're fine, and then they leave. So thinking about the different timing, how long a patient is going to be in that chair and what that overall journey is when the patient enters the infusion or injection clinic to when they leave the infusion injection clinic.
But when it comes to drugs for behavioral health, it has been so much going on. So one great example on the schizophrenia is Cobenfy. This is a new state-of-the-art oral drug that got approved last year from the FDA. It has promising results that has better adherence to taking the drug because it has less side effects, which is great for this population that has been an issue where they're not adhering to the drugs because there is side effects with it. One being gaining weight. People don't like to gain weight. Watching how much that drug is starting to be utilized is one area. Another big one, I can't talk about behavioral health and drugs without talking about all of the excitement with the psychedelics. There has been a lot of research. They are not FDA approved psychedelics, but some states are now starting to approve psychedelic therapy. Colorado, Oregon, and then I think New Mexico just approved as well, where they're allowing psychedelic therapy. These are therapies that someone's taking. These drugs, particularly these, take hours. So you are in a mind state for pretty much a couple of hours that you have to be monitored by a therapist or even a medical doctor while you're on here for hours while they're treating you. But that's becoming more and more popular as an alternative to the traditional like antidepressants and traditional psychotherapy. Ketamine, that is another one that has been big. That is also not FDA approved specifically for behavioral health conditions, but it is being used off-label. And it continues to be a very popular option for individuals. It goes back to maybe the traditional antidepressant drugs and the therapy's not working for me. I'm looking for alternatives. And that's where we're seeing things like ketamine, psychedelic therapy popping up. Even though they have not been FDA approved, they're being used off-label. So there's been a lot of development there, but there's been a lot of research and there continues to be really good research around these drugs and the use of these to help, particularly for depression. I just want to add one more thing for behavioral health from an epi that I'm starting to watch for maybe a future forecast because it's starting to take off now is there's been a lot of research on the impact like social media has on people's mental stress. Also more emphasis on using like AI and avatars And we're starting to hear stories of people using ChatGPT for their therapist and using these avatars. So one thing about Epi is this continued use of AI and technology. Does that continue to isolate us socially? And how does that impact our mental health? Because we know social isolation does impact us. That's, why a lot of this has come up from COVID. We were all socially isolated, and that's one of the issues on the older population. But as tech continues to evolve like this, and people are using things like AI, particularly to have conversations, which we know some of the youth are starting to do that. How does that impact our mental health and really isolates us socially, and we don't have that human contact anymore? So that's just something on Epi that I continue to think through from behavioral health as technology continues to advance.
Jen, Emily, thank you so much for joining today to share your expertise across behavioral health and medicine. So appreciate you talking us through some of those concepts and breaking the stories down a bit further.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and/or follow us on Twitter and LinkedIn at SG2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You could find them at Vizient /podcasts. Have a great day.